That's good. Okay. 6 to 1 more minute. Hmm? Yeah. We'll start. Good evening, everyone, and welcome to another episode of PRISM Talks, Progress in Research, Innovation, Science, and Medicine, brought to you by Janakiram Foundation. It's been a delight in the last 7-8 months. I think this is our 8th or 9th talk which we're doing, and we've had various kinds of speakers give you various insights into various subjects and topics, including how to conduct research, how to write a paper, so on and so forth. Today, we have someone very interesting to talk on screening in the high-risk population. I have the pleasure of introducing Dr. Kanudeep, a public health professional with over 17 years of experience, including nearly a decade dedicated to hepatitis prevention and care among vulnerable populations such as drug users and incarcerated individuals. She has led extensive community-driven initiative across North and Northeast India, regions with a high burden of hepatitis. She currently serves as the program lead for hepatitis at FIND, where she drives intervention that strengthen prison and community-based responses and supports the broader goal of hepatitis elimination. Her work reflects strong technical expertise, program leadership, and a deep commitment to improving access to care for underserved communities. Before I invite Dr. Kanudeep, a few housekeeping things is that one is, of course, you would have noticed that all your mics will be on mute. Request you to post the questions in the Q&A box down below. Also, at the end of the session, there will be a link to a survey. Please respond to the survey so that we can share a certificate of participation with you. So without much ado, may I invite Dr. Kanudeep to share her experience. Dr. Kanudeep.
Thank you so much, Dr. Vivek. So good evening to all the incredible minds joining us today. Just allow me a moment to share my I hope my slides are visible.
Yes.
So very good evening to all the incredible minds joining us today. So at the very outset, I extend my heartfelt thanks to Chennai Liver Foundation, ICMR, NIE for this wonderful opportunity and for generous and warm introduction. So it is a true privilege to be a part of this PRISM Talk series, a platform which is both inspiring and indispensable. So today I want to take you with me beyond the high walls and closed doors into a world few have ever truly seen, a world people seldom talk about, often judged very harshly, and are scared to be associated with. And today I ask you to see it through my lens, unfiltered and real. So not just as buildings, but as public health ecosystem, complex, overcrowded, undersourced, yet full of human stories that remain unheard. And I want to take you into the world world of another population, PWIDs, people who inject drugs, a group that faces a little um, like lifetime of stigma, discrimination, and systemic neglect. You will see how these two worlds, prisons and PWIDs mirror each other, how their struggle overlaps, how their vulnerability amplifies each other, and how hepatitis C silently thrives in these shadows. But this is not a story of despair. It is a story of possibility, of innovation, of courage, and of what happens when we refuse to look away from these hardest spaces. It's a story of like how India, our teams, our partner, our prison staff, our peer leaders have shown the world what it means to reach the unreached. So I have spent nearly a decade of my life walking through these gates long before, hepatitis became a core domain of my work, and long before I joined Find India, and long before this talk was even imagined. So my journey with the prisons began in 2016 when I entered my first facility for HIV testing scale up. So I still remember the feeling, a strange, mix of apprehension and purpose, the clang of metal doors behind me, the echo of footsteps in the long corridor, the heavy stillness of crowded barracks, and the hundreds of eyes watching, curious, unsure, wondering what we had come to do here. So I had no idea then that this environment would shape my entire professional identity, that prisons would become the site where I learned the deepest lessons about health inequity, stigma, resilience, and justice. So what begins as an HIV testing program soon turned out to be something much bigger, much larger. As we screened thousands, one pattern kept returning to me. People, looked surprisingly fine, yet, something felt very off. So many had symptoms that didn't match with what we were testing for. Many had jaundice histories, unexplained fatigue, occasional swelling, strange weakness, or, past injecting drug use. But no one had ever spoken to them about the hepatitis. And then it stuck to me while discussing this with one of the jail medical officer, that something far quieter, far older, and far more dangerous was moving through these barracks. A silent epidemic, maybe a disease that hides for years, a virus that expresses itself only when it's too late. It's hepatitis C. And that single realization changed the entire trajectory of my work. I remember thinking and discussing it with the experts, like, if we can catch this early, if we can screen people when they enter the prison, we can save years of suffering and save the government crores of rupees. So because the ROI for early hepatitis C screening is remarkable. So, I want to share here, like, a few months into my work with Find India, I walked into a central prison during one of the our early, hepatitis screening drives. And it was an environment, prisons basically are the environments designed for discipline and not healing. So a young man, no older than like 28 years, approached me after his test results came back positive. So he looked very nervous and then, a bit relieved also. And finally, he spoke words that became the guiding philosophy of our entire work. So he came to me and he said, Madam, I have been inside the prison for many years. And this is for the first time, someone told me that there is something wrong with my body, and what is wrong with my body. And, this is the first time, I felt that I'm in safe hands and I will be saved. So think about this. He had been serving his sentence, his punishment handed down to him by the courts, but silently, he had been serving a second, far more dangerous sentence, the progression of a chronic disease. That day, I understood prisons are not the peripheries of public health, they are the front lines. Prisons are not isolated islands, they are deeply connected to public health. This is why, intervention in prisons matter. Here are like few realities: overcrowding and poor hygiene. Many prisons, operate at 120 to 150% of their capacities. Dormitories built for 50 people are holding 100 plus inmates. And overcrowding fuels transmission, as we all know. And not just hepatitis C, but TB, HIV, skin infections, and many more. So, and also there are like high PWID prevalence inside the prisons. Even though many prisons have de-addiction centers, the proportion of incarcerated individuals with a history of injecting drug use remain extremely high in prisons. And then apart from this, there is poor ventilation, lack of proper sanitation, limited recreational avenues, mental health stress, and high prevalence of substance abuse, and many more. And then security first mindset of the prison officials, and competing priorities for prison superintendents. Now imagine like trying to add a hepatitis component into this environment. And also on top of that, 70% of the prisoners are under trials. Their stay is so unpredictable in the prisons. They may leave in like 2 days or 2 weeks or 2 months. So this mobility makes continuity of care extremely difficult. And this talk is not just about data and epidemiology, it is about more about like human lives. It is about second chances. It is the story of a bold public health idea that the path to eliminating hepatitis C in India goes straight through our prisons and through our most marginalized communities, the PWIDs. So hepatitis is not dramatic. It doesn't present like COVID-19. There is no breathlessness, there is no fever, no emergency hospitalizations. It is quiet, it is silent, it is slow, it is relentless. So symptoms rarely appear before 20 to 30 years of liver damage. By the time people feel sick, by the time jaundice sets in or ascites appears, the virus has already taken the hold. So, cirrhosis, liver failure, cancer, catastrophic health expenditures, and families collapsing under financial burden. So, there is a lot to it. I remember a young inmate, in Punjab who told me, Madam, I had no idea. I looked so normal. I had no signs and symptoms, but his AST and ALT values were through the roof. His viral load was really very high, and he had no clue about that. So, hepatitis robs people very quietly and silently robs the government too, because late treatment is 10 to 20 times more expensive than the early treatment. And if you ask like what make prisons so vulnerable, it is precisely this invisibility. When people don't feel sick, the health system, they don't react. When the system does not react, the virus gets enough time to grow. And that is why early screening is not just a medical intervention, it is an economic win for the government as well. And here is the ethical core of our gathering. Hepatitis C is curable, we all know. We have DAAs available that achieve cure rate above 95% with a simple short course of pills. And this is a medical miracle. Yet the tragedy is that millions are still dying preventable deaths. I repeat, like preventable deaths, not because science has failed, but because delivery has failed. The failure to deliver care to the most vulnerable is a structural flaw in our elimination efforts. We cannot claim success in elimination if we consciously leave behind the most vulnerable segments of our population to suffer a completely preventable fate. So, this is the moral imperative that drives our innovations. We can call prison bit hostile, resource limited ecosystem. So working inside prisons is an extremely, different experience. You cannot fully describe until you have lived it yourself. So there are days, when you cannot carry your phone. There are days when you cannot carry your laptop. And sometimes you even cannot carry a pen and a paper, especially in high security prisons. So you rely solely on like memory, walking out after 5, 6 hours, spending in the prison and jotting down everything the moment you exit the main gate. So it is very exhausting, it is very unpredictable, and it tests your patience, it tests your creativity, your emotional strength as well. And yet, it is one of the most rewarding spaces to work in. So building trust inside a system not designed for health is very crucial. So one thing we learned very early, like prisons are communities which are complex and tightly controlled. And you cannot enter them with a medical agenda only. So, you need to earn trust. So we were lucky, almost like every prison we worked in had a functional hospital or dispensary, and that became our anchor. So we identified prisoners who were like motivated, respected among their peers, interested in health activities. So we trained them to become like barrack in charges for health, peer educators in their own words. So they were responsible to spread awareness, they explained the hepatitis in a simple language which the other inmates could understand. They corrected their myths, they encouraged participation, supported treatment adherence, helped us track patients back across the barracks. So basically they became the link between the prison staff, the health teams, and the inmates. So this peer-led component, was very important and most powerful transformations. So when prisoners became health champions, change became organic. So next is the urgency of exclusion. So why this population is a priority? If we really want to eliminate hepatitis C, we must go where the disease is, not merely where the system is convenient. We must embrace the concept of targeted universalism, focusing our resources where the burden is the highest to achieve universal elimination. The evidence is overwhelming. Globally, the prevalence of hepatitis C in correctional facilities is 6 to 40 times higher than in the general population. This is a concentrated, high yield opportunity for public health interventions. In India, studies across various states show HCV rate in prison population often sits between 6 to 15%, and sometimes, far higher depending upon the facility type. So these are kind of hotspots, hotbeds that demand immediate systemic action. So among pivots, the rate can skyrocket to 30 to 60%, even more. This community, also requires urgent stigma-free outreach and sustained treatment. These are not just high-risk groups, they are the high concentrated epidemic drivers. When we treat them right, we interrupt the most prolific transmission networks in our society. Prisons are not isolated islands, as I said. In India, nearly like 70% of the prison population consists of under trials. So this means they are highly mobile, frequently, entering and leaving the system. So they are the bridge, the crucial, kinetic link between the high risk environment and the general public. So every life saved inside is a potential infection prevented outside. Global evidence, confirms this, like treating hepatitis C in prisons can reduce community transmission by up to like 32%. So this is not just a medical issue, this is a justice issue, a public health issue, and a humanity issue as well. Because, no elimination program can succeed by leaving behind the highest burden groups. Our commitment must be total without any exceptions. So the prison environment is a perfect storm of risk and administration. Imagine, the challenges we face in delivering primary care to a remote rural village. Now, overlay those challenges with the security, administrative, and logistical hurdles of, working in a large central prison. So it is a perfect storm, a complex system designed for deterrence, not healing. So when Fine India begins working in prisons across Punjab, Chandigarh, Haryana, what we encountered was sobering. So there was no structured services, there were no systemic structured hepatitis services, testing was negligible, reactive, or non-existent at all. And the philosophy was often, that treating acute illness or not preventing like silent chronic disease. And then there was administrative inertia. Moving anything from a box of even RDT to a patient for a follow-up or required navigation multiple layers of security protocols, police permissions, and bureaucratic delays, all fundamentally opposed to the rapid response time required for a successful test and treat model. So the administrative weight was the heaviest initial barrier we faced. But with the prison department being so supportive, we overcome all the barriers that we came across. And then, equipment was often outdated or non-functional. Bare minimum laboratory facilities were there inside the prisons, which were often like completely defunct. So there existed just as a room, but not as functional clinical spaces. Then there was a follow-up was almost impossible because linkage to specialist care it required police escort, lengthy court permissions, and travel to tertiary hospitals, a process that could take weeks to months altogether. So most patients could never complete the journey. So we realized very quickly, if we do not create an entirely new model of care inside the prisons, nothing will change. We had to build a model that was not just prison friendly, but prison native friendly, integrating seamlessly into the security ecosystem with prioritizing patient flow. So these are some glimpses from inside the prison. And so we adopted a systemic approach. After preparing the prisons and completing the sensitization, we started the screening work. So screen one barrack at a time was the motto. Achieve saturation, move to the next one. In parallel, screen every new admission also. Optimize the entry level health checkup, and this meant no one slipped through the cracks. So each prison was 2,000 plus inmates. Some of the prisons, they were very big prisons with a population of almost like 4,000 people. It was almost like a small village, catering to a small village. And we also worked hard in making screening a prison mandate. So over times, through consistent advocacy, we helped embed hepatitis screening into the routine prison health system. So today, many prisons automatically test new admissions. It has become a part of the system and not a project. So this is what is sustainability. And also, humanizing health through engagement and creativity was also very important. Health education inside prisons cannot be a PowerPoint lecture. So we try to create joy inside a joyless space. Slogan competitions, street plays, nukkad natak, quizzes, singing events, drama performed by inmates, awareness rallies inside prison campuses. People participated very enthusiastically. Health became a conversation and not just a command. For many inmates, these were first moments of recreation in months. For us, these were the tools of empowerment. Breaking the cycle, turning barriers into catalyst for change. When we talked about hepatitis elimination in India, especially in prisons and among PWIDs, it is easy to become overwhelmed by the enormity of the challenge. The structural barriers, the stigma, the lack of resources, the absence of priority. But I have always believed something very profoundly and very simple. Systems don't change because conditions change. Systems change because people decide they must. And people, real human beings in real prisons and in real field settings, taught me this every single day. From 2016 onwards, stepping into prisons became a part of my identity, not just my work. Nearly a decade later, the walls felt familiar, the corridors were more recognizable, the patterns were predictable, but the determination remained as strong as the first day. So I have seen Indian prisons health system evolve brick by brick, policy by policy, and person by person. And the hepatitis fight is finally taking shape because people inside the system, health staff, prison officials, and inmates, they begin to see themselves as part of the solution and not just the setting of the problem. So, let me take you deeper into the barriers we encountered and strategies we used and the innovations that transformed the landscape and the lessons that that every country can learn from India's journey. Talking about the first barrier is the simplest and the complex of all the barriers, the stigma and low awareness wall. So awareness first and testing second was our motto. We never walked into the prison with just needles and forms. We walked with conversation, with posters, with interactive sessions, with simple analogies. And what happened next was a magical. When people, understood the risk, the refusal rates dropped to almost zero. Everyone wanted to know their status, and that was a big win for us. Coming to the next barrier, the high mobility and the loss to follow up. As mentioned, under trial population is approximately 70% of the total population and is highly mobile. So a prisoner diagnosed in one facility might be transferred before the confirmatory RNA test returns, or they might be released entirely before the treatment could begin. So this constant movement is a public health nightmare. Diagnosis without treatment is ethically fraught and epidemiologically useless. So continuity of care collapses at the gate, rendering our initial diagnostic effort void. So later, we tried to zip this leak also with lots of advocacy efforts with the prison authorities. We made it mandatory for the outgoing prisoner to seek clearance from the medical officer before he or she is released from the prison. And also, our under trial strategy included screening them the moment they arrived, like admission day testing became a norm. And then starting treatment immediately whenever it was clinically safe, and coordinating with the legal officers to ensure that the treatment status was documented before the transfers, provide clear treatment cards so that they can travel, the treatment cards can travel with the inmate, and communicating with the receiving prisons if they are moving from one prison to another, so that the continuity was ensured, and also linking new released individuals to the NDHCP facilities outside. Sometimes, the turnaround time was so fast that we could screen, diagnose, and counsel, and started them on treatment on the same day, and that shocked us also. Then comes the non-functional laboratory access. This was one of the hardest practical challenge. Many prisons had only like bare minimum laboratory rooms, and most equipments, if even if they existed, they were like non-functional or uncalibrated. So with months of advocacy, meetings with superintendent, and endless coordination with the health department, we managed to partially revive some of the diagnostic services like basic biochemistry, sample collection and transport, and safe storage. But hepatitis C required more. We knew waiting for full lab upgrades, would cost us lives. So we introduced point of care innovations, rapid diagnostic RDTs, sample transport linkages, decentralized blood collection points, and that transformed access overnight. Testing moved from once in a while to consistent and scalable. That was a major achievement. Coming to the next barrier, it was like slow linkage to specialist care. So the traditional referral pathway was a bureaucratic torture track. So earlier, it was a positive screening meant waiting, then referral, then paperwork, delays, follow up, under trial being released early, or missed treatment opportunities. So made an effort to change this. As this system was designed to fail. Our breakthrough came by flipping the model. We trained the medical officers inside the prison in partnership with the National Viral Hepatitis Control Program and PGIMR Chandigarh. So now all the non-cirrhotic patients are initiated on treatment right inside the prison without any waste of time. And only the complicated cases were referred to the specialist centers. And for those also, many times, we make use of telemedicine and teleconsultation to support that decisions. Then lastly, like during COVID times, when everything shut down, this became our lifeline, because we don't know when such a virus or situation might come again. We hope not. So we personally delivered RDD kits during lockdown, when supply chains froze, when vehicles were not allowed, when movement was restricted. We still ensured testing never stopped. We personally carried HCV RDTs kits, sometimes in private cars, sometimes I drove it down, sometimes coordinating with police checkpoints, just to ensure that the prisons did not run out of test kits. And this is what real service delivery looks like. Not glamorous, not celebrated, but life-saving. So this resilience proved that human dedication can overcome any systemic failures. So there is another crisis, the burden among the PWIDs. So parallel to our prison work, our teams focused intensely on the people who inject drugs. Communities across like Punjab, Haryana, Mizoram, and Meghalaya. So this group is marginalized, criminalized, and often suffer stigma. So PWIDs are undeniably at the heart of the India's hepatitis epidemic. So with exposure and prevalence rates far exceeding the prison environment, we recognize that the approach needed to be fundamentally different. Coercion and control would fail, but trust and outreach must prevail. So we learned something very vital in this context. PWIDs trust people. PWIDs, they don't trust systems. They trust someone who has walked their path, someone who understands the fear of relapse, the fear of shame, and the daily fight for survival. The insight compelled us to build systems that earn trust, utilizing peer navigators, mobile camps, and community outreach, we learned that bringing the service to them, removing judgment, and having a cured peer advocate for testing is the most powerful public health tool ever available. So this became one of the most responsive, high adherence hepatitis service model in the country, proving that human connection is the most powerful catalyst for public health change. Let's talk about impact in human terms. So hepatitis C is not a mild infection. If untreated, it can lead to like chronic liver disease, cirrhosis, liver cancer, liver failure, death. And in India, hepatitis C contributes to hundreds of thousands of deaths every year. But the tragedy is that most of this is preventable. When someone, progresses to cirrhosis or liver cancer, the cost to the system skyrockets. So there are multiple hospital visits, imaging, biopsies, intensive care, high cost medication, loss of productivity, catastrophic household expenditure, and sometimes, the need for transplant. A single liver transplant can cost more than 10 to 20 years of early screening and treatment for an entire prison. Imagine. When we can screen early, treat early, and prevent progression, the ROI is not marginal, it is huge, it is massive. So every cured patient is a life saved, a family protected, a daily prevented, a long term cost avoided, a community made stronger. And when we do this at a scale, say in a closed setting like prisons, the impact multiplies. So, reimagining the delivery model, we tried 5 different innovative models of care. So, our successful screening of 33,000 plus inmates and linkage of 80% to care was not luck. It was a result of deliberate, innovative redesign of care pathway, basically. So, we applied the core principles of innovation, research, and medicine to build a system that was robust, decentralized, and human centric. Talking about the innovations, so first one was telemedicine and teleconsultation as a specialist backbone. So this was a game changer, especially during COVID, but also during peacetime. Given the security restrictions on specialist visits, specialists could not enter the prisons frequently, and also they don't have that much time, but clinical services were never stopped. We established an entire specialist care ecosystem built virtually, connecting prisons directly to the hepatologist at PGIM or Chandigarh and other tertiary care centers. So zero risk, security risk was there. This eliminated the need for the high risk groups, expensive police escorts, taking prisoners to the tertiary hospitals. And then there was instant decision making was there, treatment decisions and clinical guidance, especially on complex cases or during, unexpected patient symptoms were made in real time. And then there was uninterrupted care. When hospital OPDs were closed, prisons received uninterrupted expert care. And then the second innovation was the decentralization with point of care testing. So since the centralized prison labs were not functional, cumbersome, or administratively slow, so we had to democratize the diagnostic tool. So we deployed HCV HCV antibody RDTs for immediate results and counseling. Portable HCV RNA confirmatory options were also possible and made available. And the simplified, reliable cold chain sample transport system was also made available. So this reduced the testing turnaround time from weeks to 24 to 48 hours, accelerating the path to treatment and minimizing the window for loss to follow up. So this POC model, combined with the RDTs, allowed us to operate at a scale and speed that the traditional public health system could never match. And then another decisive flip was the treatment initiation right inside the prison. So this was the boldest intervention and the key to our high linkage rate. So we sincerely thank Government of India for supporting this initiative of ours. So we effectively, created a microelimination hubs within the prisons themselves. So this required significant policy advocacy, demonstrating that the MOs with the adequate training and teleconsultation oversight could safely, manage treatment immediately with, With this, we cut the linkage time from months to days. So this was a big paradigm shift. The burden of treatment initiation moved from the inaccessible tertiary centers to accessible points of diagnosis. So complicated or cirrhotic cases were the only ones referred to external specialists or via teleconsult networks. And this single innovation, transformed the system from a funnel of failure into a rapid conduit to care. And then was the digital tracking and accountability system to counter the high mobility of 70 percent plus under trial population. We build a robust digital follow-up system. The movement of under trial prisoners between judicial districts and the facilities is constant, and paper records are easily lost. So this digital system came very handy. It tracked every HCV positive inmate across facilities, providing a unique digital identifier tied to their clinical status. It coordinated, communicated between prison health posts and district hospitals and community ART centers upon their release. And it also ensured that the continuity of care was maintained across the entire journey from diagnosis to SPR 12. And this digital spine ensured that no one fell through the cracks due to mobility. And then last but not the least, the service continuity through unprecedented crisis. Our resolve during the COVID-19 lockdown demonstrated the political will and personal effort can overcome logistic catastrophe. We were told to shut down. We refused. We maintained continuous service by creating safe, isolated testing stations within the facilities, often adapting unused spaces into temporary clinics, implementing emergency protocols for telehealth and decentralized drug delivery by bypassing central supply interruptions. Crucially, personally guaranteeing the supply chain to ensure kits never stopped and screening never stopped. So this commitment signaled to the inmates and the staff that their health was non-negotiable, even during a global crisis. So this extraordinary effort from our side proved that service must be crisis-proofed and not just crisis deferred. Talking about the models for scaling the future of public health delivery. So Find India model is now a sort of global blueprint for three key scalable strategies. One is like the decentralized test and treat hub. Testing occurs at peripheries. Treatment for non-complex cases is initiated at the periphery by trained staff. Specialist support remains at the center, delivered virtually. So this model is fast, high yield, cost effective, and minimizes the bureaucracy, optimizing resource allocation where it is most impactful. And then the second was the peer navigator model, the true catalyst model. So we cannot overstate the importance of lived experience. Peer navigators, former PWIDs or cured inmates bridge the gap between the clinical science and the street reality. So they speak the language of trust, understand, and social determinant of health in their community. And also, they help dismantle the stigma that clinicians cannot always read. So their role is very critical, increasing testing uptake, improving adherence, and ensuring patients complete the journey to cure. Trust is the currency of linkage. And then last but not the least, radical integration of the services. Fragmented care is the enemy of vulnerable populations because it's very difficult for us to reach out to them. So we must merge hepatitis C services with existing robust HIV/AIDS program, TB screening, and OST sites. So every contact point must be a diagnostic opportunity we should not miss, leveraging existing funding streams and staff infrastructure also. So this maximizes efficiency and crucially, normalize testing, reducing the specific stigma attached to hepatitis. It treats the whole person, not just a single disease. Talking about the strategies behind the 80% linkage success, I would say that 80% linkage rate is phenomenal, and especially in these settings with these populations. It was achieved by prioritizing the patient experience above all else. So moving from a system-centric approach to human-centric one. So first was the same-day linkage pathways. The moment of diagnosis is the moment of greatest vulnerability and highest motivation. So we moved heavens and earth to ensure that the testing, confirmation, teleconsultation and treatment decisions were all made within like 24 to 48 hours. That was tough. It was not easy. And then the zero barrier treatment initiations by empowering the MOs inside the prison and at the OST sites to start the treatment inside the prisons and at the OST sites. So we eliminated the need for travel, external referrals, and lengthy waits. The cure was available at the point of care without expectations and unnecessary delays. And then there was active follow-up and not passive referrals. Our team and peer navigators, actively tracked, counseled, and followed up with every single patient, both inside the prison and post-release. Gaps do not close themselves. People have to close them. And then last but not the least, sustained capacity building. So we did not just, dump equipment. We invested in people, trained medical officers, nurses, paramedics and medic staff, and community workers, ensure that the model became sustainable, owned, and replicable by the state. So this transfer of ownership is the ultimate metric of sustainability. So if you have ever been inside a prison, you know how monotonous days can be. There are like, you lost the track of all the weekdays, weekends, when is the weekend, weekday, no major festivals are there, but 26th January and 15 August are celebrated in a big way. There are no outings, no family dinners. So human needs joy to stay alive. So this is why we created events not just for awareness, but to bring back life into the system. Street plays, slogan, painting competition, music, singing, group quizzes, health rallies, and it worked beyond anything we expected. Hundreds of prisoners, they participated, not because they were forced to, but because these events made them feel human again. So I still remember in a prisoner, in Punjab, who won the slogan contest with a line that still stays with me. It goes something like this: that jail ki darwaze band hai, but umeedon ki roshni to khuli hai. And awareness becomes community, community becomes ownership, and ownership becomes change. So I want to share one very transformative story. So data convinces, but stories, they transform. I want to share like two accounts that illustrate the ultimate return on investment, the restoration of dignity, purpose, and life itself. So in a large central prison, one of the central prisons, a man had lived with chronic hepatitis C for nearly 10 years, maybe. He kept silent due to the sheer terror of diagnosis and certainty that no one is going to help him. How will he get the treatment? He told our counselor that knowledge of the disease was a constant knowing factor for far worse than his loss of freedom. So when we initiated point of care testing, he tested positive. So he didn't react with fear, but with an overwhelming cathartic relief. Like he told our counselor that the disease has been a longer punishment than my prison term. Now I have a hope. So this was like a very heart touching thing to hear. So this was not just a medical diagnosis, it was more of a psychological emancipation. So he completed the treatment right inside the prison walls and achieved SPR 12 and was cured before his release date. So when he left, he was not only physically healed, but also like mentally rebuilt, empowered to be an advocate to his community. And his medical cure became the catalyst for the rehabilitation and reintegration. And the second story is of the PWID navigator who became a healer. So one of our most effective peer navigator was a former PWID who had completed his own HCV treatment journey. So he knew that the community's language, their haunts, and their deepest fear better than any of us. So he could walk into a marginalized camp and simply by sharing his own story of survival and cure and achieving immediate trust, could achieve immediate trust. He personally brought around 200 plus individuals into testing and linkage. He once told us with determination that if I could get cured, so can they. And if they can get cured, their children won't grow up like I did. So this is the power of lived experience, transforming personal survival into public health. So it's the highest form of a motivation, a healer born from a survivor. So this evolution didn't happen overnight. So, back then there were no structured prison screening, no POC, no trained prison officials, no telemedicine, no routine hepatitis admission screenings, no peer health champions, extremely low awareness, stigma everywhere. And now, prisons, they are screening tens of thousands of people. There is POC testing, which is integrated. MO is trained and is initiating treatment. Specialist teleconsultations are there. Prison policy prioritizes the health, and refusal rates are extremely low, and awareness activities are also, and peer models are also thriving inside the prison. So this evolution, it did not happen overnight. It took years of persistence, years of walking into the prison empty handed, years of fighting to make hepatitis part of the conversation, years of earning trust, slowly, genuinely, constantly. And today, when I see hepatitis testing booths set up in the prison hospitals or see, inmates explaining hepatitis concepts to each other, or hear prison officials proudly reporting the screening coverage, I realize this evolution didn't happen overnight. And I realize we did not just build a program, we built a movement. And this makes us feel so proud. And, people often ask, like, why invest so much in prison health? And I usually end up telling them, because prisons are not isolated islands, they are deeply connected to communities. Every prisoner eventually returns home, and every untreated infection becomes a community risk, and every missed diagnosis becomes a missed opportunity for elimination. Our work has created ripple effects that extend far beyond prison gates. The data we presented, like 33,000 inmates screened, 80% successfully linked, is not a statistical triumph. It is a metric of a moral commitment. It is a legacy of what happens when scientists, doctors, and government partners decide that no population is too difficult, too marginalized, or too undeserving to be saved. So we have demonstrated that even amidst the chaos of pandemic, even behind the highest walls, systemic screenings, telemedicine, decentralized care, and community trust can achieve elimination level linkage rates. So we have proven that the cure must follow the disease. And the final call to action is a question of will. India, by virtue of its scale, diversity, and innovation ecosystem, is positioned to become a global leader in hepatitis elimination in prisons and high risk groups. So, what we have proven through our work is that hepatitis testing can be done in closed settings. Treatment can be started inside the prisons. Linkage can be achieved even for mobile populations. Peer models can thrive. Telemedicine can sustain services. Stigma can be reduced. Health seeking behavior can transform. Prison can be centers of public health excellence. What we need now is scale, investment, political commitment, especially and specifically national guidance, cross state collaboration, solid integration with the national program, sustained monitoring, supportive supervision, digital solutions for tracking. And India can demonstrate to the world what health equity truly looks like, not by focusing only on the easy to reach population, but by standing with the most marginalized prisoners, PWIDs, and people living on the fringes. Because elimination is not achieved until everyone is included. So I want to wrap up by asking you to think, not as scientists, not as policymaker, but as human beings. Think of that young man, standing in the cemented prison block, finally receiving the truth about his health, and with it, a hope. Think of the peer navigator who turned his past struggle into future of healing for hundreds of others. The darkness we begin with, the black screen of neglect, is not inevitable. We are the ones who hold the power to draw that single, saving white line. That line is not just the DAA pill, or it is the line of dignity. It is the line of universal healthcare justice. So when we ignore population, we just don't fail them. We compromise on our own collective conscience. I know and believe that all of us are putting our best efforts already, but let us leave this space today with a promise that we will not rest until the cure is available, not just in the hospitals, but most critically, behind every high wall and to every harm reduction site. So the cure is here. Let us find a will to deliver it. And before I conclude, I want to offer my deepest gratitude to everyone who made this journey possible, to the health department, to the prison department who opened their gates and their hearts as well, to the officers and the staff who stood with us at every step, to the incarcerated individuals who trusted us and allowed us to learn from their lived realities, to the Government of India team for their constant guidance and unwavering support throughout, to PGI for their expertise, insights, and for always welcoming us with such openness, and to my incredible Find India team, whose commitment, compassion, and perseverance turned vision into action. So this work begins and belongs to all of you. Thank you for walking with us. Thank you so much. We are open for questions.
That was brilliant. I mean, that's I think that just came from your heart rather than anything else. I think it just shows how involved you were over the last decade or so in doing this amazing work. That's sensational. Um, and thank you very much for sharing your story, sharing the data, and showing us an opportunities to do something new in other parts of the country also. And that is why, and that is the idea where we started this Prism Talk, where people can share ideas and thoughts so that we can collaborate and do more work, do good work, and learn from others. So thank you once again. So I'm going to invite just one more person, Dr. Janakiram. Dr. Janaki, are you here? Janaki, you're on mute.
Yes, sir. I'm here, sir.
Oh, right. Thank you. Thanks for joining. So Dr. Janikaman is I think he just moved from that position to some other position, but he was a joint director in the Department of Health and Family Welfare, Government of Tamil Nadu. And he's done a lot of work in the prisons, and he's as passionate as you. So, and Dr. Janaki, could you just share in a couple of minutes, your thoughts about Dr. Kanudeep's work, and of course, what you have done here in the prisons in Tamil Nadu, please.
Yes, sir. Sir, please stop me if I'm exceeding the time limit.
You
So
have
that
three
this is the
minutes.
area. Yes, sir. Yes, actually, in Tamil Nadu, first of all, I thank you and Dr. Vaishnavi, sir, for inviting me to this wonderful webinar. Thanks to Dr. Kanudeep also. Like in Tamil Nadu, we are having around 148 prisons, and I'm having the privilege to visit almost 120 plus prisons. So I think no other prison officials would have that opportunity to visit this much number of prisons. So I had the privilege actually. So usually prisons were broadly classified as central prisons, district jails as well as sub jails. If we take while approaching individuals from the perspective of health, usually correctional medicine is the one which was not yet developed in a country like India. But as far as infectious diseases are concerned, HIV program, after 2018, hepatitis B and C started to invade the prisons in order to as a public health control measure. But there were a lot of lack while addressing these infectious diseases. Usually, while approaching prison, we have to understand certain things. One is the constitutional rights of the prisoners. The next one is the legal rights with respect to health for the prisoners, and next one is the human rights. So we will be standing at the junction of these three rights. So always there will be some policy the prisoners inside the prisons, there will be some governmental orders will be there, and every other health individual who is sitting inside the prisons and whoever is coming outside from the prisons have to stick to that policy while taking up these several measures with respect to health and medicine. With respect to HIV and hepatitis B, usually, in case of central prisons, we are having type A and type B type of hospitals. Type A type of hospitals means which will be having 50 or more number of beds, whereas type B type of hospitals are the one which will be having a less number of beds. Usually, in the central prisons, we'll be having mostly we are having type A type of hospital setup inside the central prisons. Whereas in case of district and sub jails, those uh, prison institution will be mapped to the nearest health facility, which may be a public health facility or it may be under a public private partnership, but mostly it will be linked to a public health facility. And on a fortnight basis, diseases like HIV, syphilis, sexual transmitted infections, hepatitis B and C will be tested on a fortnight basis in those prisons which were located in district as well as in the sub jails. Whereas in case of central prisons, there is an inbuilt system we are having, and we will be having a separate infrastructure so that we can do all the testing and treatment services. But in case of chronic infections, as well as in case of some liver cirrhosis or carcinomatous conditions, where we used to refer to the nearest medical institution, that to a government institution, which will be mapped with the central prison, and that institution will be have to take the follow-up protocols also. They have to instruct the prison officials to follow the patients routinely with the guidance of the local resident medical officer who is working inside the prison. So this is how we'll be the dynamics is working, but there were a lot of lacunae. I have discussed several things with Dr. Vivek sir also, like the non-functional laboratories, which Dr. Kanudeep has noted it, and there were there are certain issues like lack of kits, lack of treatment services. And I've seen one person under which health system prisons were placed. Usually, the Directorate of Medical and Rural Health Services will be taking care of the prisons, but in separate states, Directorate of Public Health is also taking care of that. But what I feel is NACO is an for HIV/AIDS there is a separate vertical program is there, whereas in case of NVHCP there is no separate public health component. So if we are leveraging the services from HIV and sexual transmitted diseases program, I think we don't achieve the targeted individuals. So I hope that won't help us. We have to develop more number of peer mobilizers inside the prison itself, and sensitize more number of individuals with respect to hepatitis B and C. So already the prison officials would have identified a lot of individuals to take care of or coordinate certain things inside the blocks of the prisons itself, because I think Dr. Kanudeep has mentioned a point. It has to be decentralized, because each and every part of the country's prison has a different dynamic pattern. For example, in each and every block inside the prison, will be they are overcrowded. Most of the people are talking about hepatitis C only, but actually hepatitis A is also more prevalent among where there were overcrowding in that particular block. I have seen a lot of cases where fecal-oral transmissions are comparatively higher in certain blocks of the prisons, as well as hepatitis B and C.
Can you just, because there are a few questions which we need to ask Dr. Kanudeep also.
Oh, okay, sir. Okay, sir. Okay, sir.
So can you just
So
give me
maybe
one answer roughly? Do you have any numbers? How many you've screened? What is the positivity? How many linkage to get? Do you have any rough numbers at all?
yes, sir. With respect to hepatitis C, the prevalence in Tamil Nadu is around it ranges from 6.9 to 7.8 percentage.
Aye.
Whereas in case of hepatitis B, it is around 3 percentage.
Lovely. Thanks for all the inputs. Do stay with us. I have a few questions for Dr. Kanudeep. I'm just going through those questions. One is, Kanudeep, are you there? Hi. Thank you. So one is, of course, from Navneet. Of course, clearly he's congratulated. Everyone congratulates your amazing work. First thing is, where do prisons fit with the government's overall strategy for addressing hepatitis C? Is it routine hepatitis C screening also offered to prison staff, or is just limited to inmates? And the third question which he's got is, have you considered integrating screening for other infections along Hep C? I think you mentioned that, right? Integrating with other infectious diseases. You're on mute. You're on mute. Yeah.
Yeah, I was not able to unmute myself. Yeah, thank you, Dr. Navneet, and for your questions. So this is very tricky. So I mean, like after we started working, bringing our focus onto the prison interventions and the positivity that prisons have, uh, especially in the north and northeastern part of the country. So government has also taken into account that the prisons are important for doing the doing the interventions there. So it is not part of the, like, per se, the important part of the NVHCP guidelines, but now the focus is being shifted to screening. And the prison officials are not included as, they are not to be part of the regular screenings, but the prison officials, they have requested, wherever we have gone for the testing, that to screen the staff first, the prison staff first, and that brings more confidence in the prison inmates also, that the entire team is getting screened. So the focus is, I mean, like, even if the government is not focusing directly on screening them, the staff themselves, the prison department themselves, they are more paying more attention to getting everyone screened. And for the other question, a routine hepatitis screening is offered to the prison staff. Yes, now it is part of the program for the prison, not per se for the government, from the government side, but the prison officials, they are sensitized enough to get themselves screened. And have you considered integrating screening for other? Yes, of course, like hepatitis C was our main focus, but we don't want to miss the opportunity to screen for hepatitis B as well. So we are doing it for hepatitis B and C both. And also, because we are leveraging this on the HIV system, so we were screening them, helping the government screen them for the HIV as well, the routine screening. So we are doing that. Do we have any other questions? Yes.
Dr. Sukhwinder Singh. Apparently you were with him made some visits with him. He wants to know, where was the viral load done?
So, yeah, that makes me nostalgic. Yes, we went to the Kapurthala jail together. So we used to get the viral load done from an external agency. We tried to get it done from the government settings. But, since the positivity is coming out to be very high, and we had to, outsource the viral load. So we done from the external laboratory, the viral loads.
And of course, Navneet wants to know whether a shorter form of treatment such as GP would be beneficial.
Yes, of course, the shorter treatments will be more helpful because, as I mentioned in my presentation, that 70%, more than 70% of the people, they are under trials, and we don't know when they are going to be out of the prison. So, shorter the treatment, better the coverage could be. So, yes, Navneet, that might be helpful.
And then, of course, the final question from Devahi is that were the family members of the positive patients screened?
We are doing it for the PWIDs, but it's very difficult to get it done for the prison inmates. So yes, we are doing it for the PWIDs because that's doable.
Is it it's what's difficult to get in touch with the families and then
For PWIDs, see, majority of the PWIDs, they are not staying with their families, or they are being disowned by their families.
yeah.
So for the few, we try to track their regular partners or the family members. So we try to reach to them through the peer navigators because they know the community well, their people well. So we try to convince them to come to the OST sites, to the drop-in centers, where we can screen them. So we try to screen the family members of the PWID.
Lovely. I think no more questions, but that was a brilliant session. Thank you very much again.
Thank you. Thank you so much.
Thanks a lot. And of course, to all the participants, if you can fill up the survey form, then it'll be helpful so we can improve our sessions and do more different types of sessions. And of course, we can send you an e-certificate also. So thanks once again to Kanudeep, and thanks everyone for joining PRISM Talks. See you again next month. Have a very good evening. Thank you. Thanks, Kanudeep.